Well, look, we're going to bounce, I think, straight in now to our roundtable event. If we start that a tiny bit early, then do you know what? We've got even more time for Q&A and discussions and all that kind of thing. I can see David is here, Elaine is here, Devika is here. Great to see all of you. How have you been?
Good.
This is designed as an interactive question, by the way.
I loved Phil's quote. That's definitely gone in my little quote folder. That was fantastic.
You've grabbed that as well. You've grabbed that as well, David. Well, look, this is the beauty of an event like this, that you just never quite know what you're going to hear or see in the next few minutes. And that's certainly the case for the forthcoming roundtable, because if you didn't realize it, everybody, this is the final session of today's event. It's around leadership mindset, and it's a critical point here. It's the mindset around leadership for inequality, and that could be across health and social care. We're going to be really exploring the theme of inequality, both from the perspective of the people whom we serve, but also the people who we lead, and how do we do that more effectively? How do we consider inequalities? How do we tackle inequalities? How might we address perceived inequalities? How do we even find out whether inequalities exist or not? This is a massive subject, and I know from my own post tray that I receive as the chief executive of the Institute, this is something that perturbs and concerns a lot of you. Many of you work, I mean, if you look at Maher, for example, working at St Helens and Knowsley, from Anne's presentation this morning, you look at the levels of deprivation in the population that St Helens and Knowsley NHS Trust serves. You can see why tackling inequality is such a huge element of what Anne is concerned about, because if you tackle that inequality, what do? Well, you cut off the need for some of the services that Anne is required to provide, many of them born out of inequality. And only quite recently, I was privileged, and I mean privileged, to be at a Health Education Improvement Wales mental health conference, listening to a fantastic presentation about the effect of inequalities on the demand for services from mental health trusts in particular, and how ludicrous it is that we go about treating people only to return them to the same environment which made them poorly in the first place, and how completely insane that is from the perspective of using our money effectively. While I've been palavering along, I'm delighted to say that the entire panel has assembled itself here. So allow me, if I may, just a couple of moments to introduce everybody. We have the fabulous Elaine O'Brien, a long-term supporter and fan of the Institute. Elaine is the lead health network strategy executive at Oracle Cerner, and we're very grateful for Oracle Cerner for their continued support for the Institute and all that we do. Elaine, it's lovely to have you with us. We have David Maher. David is Deputy Chief Executive and Managing Director at Northamptonshire Healthcare NHS Foundation Trust. Northamptonshire Healthcare, I'm delighted to say, have just renewed as our regional hub for the East Midlands, and it's absolutely fantastic that David can join us. We're really looking forward to that. David, I should say, Northamptonshire Healthcare is a community and mental health provider, so it's great to get that perspective. We have Nikki Hosty, who's Assistant Director of HR, Workforce and Organisational Development Directorate at fabulous Calderdale and Huddersfield NHS Foundation Trust. Nikki, it's wonderful that you can join us today. We're really grateful to you for giving up some time. And last but absolutely not least, an organisation that's been mentioned several times today in various different presentations. We're privileged to have Devika Wood. Devika is Senior Vice President of New Markets at ORCHA, the Organisation for Research of Care and Health Apps. I don't think I'm anywhere near that, to be quite honest.
Review of Care and Health Apps, yeah, close.
Close, but no cigar, no cookie, you know. But look, what do you think about that, everybody in the audience? What a galaxy of talent, insight, and expertise we have here. So I'm just really going to act as sort of facilitator and question master here, try to give everybody the right amount of fair time so they can express themselves properly. But I would just like to start with, how do we best understand the extent of inequality amongst the people whom we serve? And that I would include staff in that, as well as the citizens whom we serve. How can we collect up information, data that gives us a proper, reliable picture of what is currently the situation? I don't think, I'm not going to come to you first, Elaine, because I'd like the Oracle Cerner view on this a little further down the line, if I may. If I might start with David and Nicola, I don't mind which of you goes first, but I'd be really grateful if one of you could just, how does David, let's make a decision here. David, if I was to ask you, what sort of data and how do you collect that data informs your view of inequalities amongst your staff and the people that you serve?
Hello, everyone. It's really good to be here. And I sat in on some of the earlier sessions, which were fantastic. So thank you for that and for the opportunity to speak with you. I guess for us, I mean, the data we get predominantly is obviously our public health data, which is, people would be familiar from the joint strategic needs assessments, which are very much population-based assessments of needs across a geography. So generally how we use that in our trust is to then segment that across our primary care network. So we see it at a GP practice level. And that then informs how we then apply our interventions across our teams. We've got a set of data then that filters into some management tools. So we've got a management and supervision tool, which then helps us segment that data further. So we can take a look at the risk profile within that. So some communities will have greater prevalence towards diabetes or schizophrenia and so on. So we can then see where those needs are presenting across those communities using those kind of technologies to help us do it. So I think it's the public health prevalence data. And who would have thought we'd all be able to talk about case rates and prevalence with such ease following COVID, and for all of us to speak now a common language around epidemiology. So it's very much looking at that. And I guess for maybe bring Nicola in, the other thing is be curious, I think is the primary modus. Before you look at any data, you've got to have a curious mindset. Why is it like this? Why is there a coagulation or a collection of specific disease groups in that population in that particular part of the county? Why? So I'll give you an example. So Corby is a town near, well, it's in Northamptonshire clearly, but I live near it. And it has a big ex-Scottish population. They came when the steelworks in Scotland closed down. Those populations moved down to Corby where there was steelworks. Mittal, some Indian steel companies were there. And they have a particular profile. So we see if teenage pregnancies rise in Corby, we see a very similar set of demography information feeding through from Glasgow specifically, and similar within COPD and respiratory illnesses. We see the two matching close, and that shows the legacy of inequalities working their way through generations. And that's really important that you ask the why. Why do we have so much respiratory illnesses in Corby? You can track it back to the fact that their families, their generations came down, worked in heavily respiratory deleterious industries, and then they moved down to this county and have brought some of that prevalence with them. So those are really important bits of detail to kind of use when you're thinking about planning services, that you actually can understand the why, be curious. What do you think, Nicola?
Well, I agree. Curiosity is the key, as well as using the usual channels to access the information. At CHFT, we use social deprivation data and match that against access to our services. And then we ask for feedback around our services to determine.
I'm sorry to interrupt you, Nick. Just pull that apart a little bit more. So you align deprivation data against the experiences of the services that you provide. I think that's what you said. Could you just give us a little bit more insight into how you do that?
Yeah, so we look at postcodes of the patients that access our services and align that to the areas that they come from, and then we have a look at in respect of how many patients are accessing our service dependent on the social deprivation data, and that would link from 1 to 10 being the people who live in the most affluent areas, and then we can measure access to our services based on that. So that's what we measure, and that gives us that great data for the health inequalities when that comes to patients and accessibility and the level of care that they receive. When it comes to colleagues, we measure when it comes to workplace race equality standards, the DES, the disability standards, the staff survey. We've got Ask Brendan's, which is our chief exec, and we basically have an open door policy, no matter who you are in the organisation, to generate great dialogue and open discussion.
Well, that's perfect. Thank you, Nikki. That's a great answer, by the way. Thank you very much. Elaine, come on, you're the keeper of the, well, you are one of the keeper of the keys for data analysis and such like through the great work that Oracle Cerner is able to do. How would you look at the sorts of data that David and Nicola are collecting and then help them to figure out, so what do we do with this?
Well, I would say we're a custodian of that data. So just to kind of clarify that bit. So what we will do is provide the the extensive platform that you need to be able to hold data and be able to then use that data to turn it into intelligence. So if I use an example that some of our clients, I could give a couple of clients examples specifically around core 20+5, because it really kind of helps everybody focus in, because there's so much to do. But if we look at the maternal pathway and Black women in particular, we're able to see that they often get, and I'm going to put inverted commas, get lost after they've had their child, and are at very high risk of having diabetes. And those follow-up treatments and tests that are needed to ensure that those women who are at risk are actually monitored and given the right advice, support and guidance so that they can manage that and identify if they continue to have diabetes, because that has a very much a long-term effect. So that group is identified as needing particular focus, and our client in Lewisham has done that. But also there's other areas that are sitting in different populations, which is around stroke, whereas much more in the white population, where those that are smoking and often are in deprived areas are at higher risk of having a stroke. So atrial fibrillation is particularly one of those areas, and I've been able to identify those. And I've actually put in whole pathways that are digital. So we don't even bring the patient into the hospital anymore, or they're identified through an algorithm, they're reviewed remotely, they're texted to say that, to explain to them that they might benefit from having a remote check of their pulse, and then sent out their ECG recorder as well. And then the consultation happens virtually as well. So, I mean, the world is really changing about how we engage with those folk who may be in work and aren't able to afford to take the day off work, or maybe at home looking after an elderly person that they have to care for, or children. So it starts really to open up the ability to reach people that we may not have been able to reach before.
And it's quite clear, you know, we've never had so much data, have we? I mean, it's coming out of every pore of every organization. We've got the data. It's kind of, how do we intelligently prioritize and use that?
Yeah,
positive effect, I guess.
Yeah, and I think it's quite scary actually some days when you see how much you've got, and that's why we've found working with our clients having the core 20+5 has actually really helped people focus. on those things. Now, it doesn't exclude other things, but what it does is say, these are the things that we know are problems in society, and therefore they do need that focus, and that's the expectation. So it's just help kind of contain things so that it's easier to get on with work.
Thank you, Elaine. I'm going to come to Devika now, and you're a bit of an outlier in regard to the round table. I don't mean that at all disparagingly to you, Devika, but you know, you're coming at this from the point of evaluating technologies that can help to understand and deliver solutions and so on. Are you looking at this whole issue of inequality at all and figuring out whether you can even recommend apps or technologies that can address this in an intelligent manner and maybe present the likes of David and Nicola with better solutions to what they're looking at? Is anything coming out of the woodwork for you, do you think?
Yeah, no, absolutely. Just a quick one. My name's pronounced Devika, but
oh, I'm so sorry. That was
everyone gets it wrong, but
no,
I always
I only need to be told once. That's fine.
No, you're all right.
My wife would disagree with that, by the way, but no.
No, at one point I was going to change my name because it got so frustrating, but then I was like, keep going.
Just keep telling idiots like me. That's fine.
No, not at all. So yes, I'll just quickly mention, because I think it was really interesting the points that we're saying, and I think someone was saying in the comments around, you know, asking people about inequalities and disparities. And I'm pregnant, and I went to my maternity clinic the other day at Chelsea Westminster, and they're an absolutely fantastic midwife clinic, so I can't fault them. I witnessed something quite interesting, which was a lady that came in. She was about my age, and she couldn't speak English. It wasn't her first language, and the nurse was trying to describe to her about doing the diabetes test that you have to do, which is basically taking Lucozade tablets and then checking. And she could not understand it. She did not understand what was being said to her, and it was all around the fact that it was just a language barrier. And the poor lady went out crying from her room, and it was quite disheartening to watch. Simple things like that. You know, we talk about data all the time, but I think simple things like that can actually truly impact a person's life. I know, I don't know what the follow-on was that, or whether they had someone that spoke her language, or whether there's, you know, there are kind of things that we have where there are content and communication and leaflets in different languages. But in that moment, you know, that could have been a matter of her not wanting to return to that midwife clinic. And then again, that impacting that lady's journey, that baby's journey. So I think it's really important to think about the human interactions when it comes to health inequalities, despite the fact that obviously the NHS is completely and utterly overburdened at the moment, but there's little things I think we can do to help. But on the technology front, yeah, exactly. That's what we're trying to do at ORCHA, and it's a topic that comes up everywhere. So at the moment, I'm in the States, and it's a huge topic over here with health inequalities and how we can use technology. And what we do is we create what we call assessment frameworks, which actually include looking at criteria for what we want to assess against when it comes to health inequalities or health equity. And what that means is we can dig into real like micro data and micro analysis on even simple things like the UX and UI of a tech solution, or the languages that it's surfacing on a tech solution, or the interface, or the ease of use of it. Even going into things like an app should be able to be used when there's data poor areas, because otherwise there's absolutely no point in having an app or a technology solution. So we are creating those kind of frameworks, and what that hopefully will help us to do is work with developers and solution creators who can then design and create digital health solutions that are specifically geared towards areas and populations where, you know, they do have health inequalities, and therefore we can then surface them through to various NHSs through our library. So absolutely, it's a real critical point, and one that we need to be focusing on more, to be honest.
All right, thank you. Look, we're getting some great answers here. Isn't this interesting, everybody? You know, we're already learning a whole heap of stuff around this. I'm going to, if I may, we've only got a limited amount of time, so I have to try to focus us onto some of the specific things that we want to address. We've got a whole heap of managers and leaders of all sorts of different levels across clinical activity, non-clinical activity, social care. They're all looking at this, and they're all thinking, do you know, we've got 2.1 9 million people work across health and social care in our country. If we assume that we're about 65 million population, something like that at the moment, you know, this is a significant chunk of our population who come to us to earn their livings and deliver the services that we require. And you can bet, you would know, David and Nicola, I'm looking at you in particular here, that a number of those people are struggling with daily inequalities to do with their ability to come to work and function in the manner that you would regard as, you know, perfect, basically. Can you help our audience today figure out, or with some ideas perhaps, around some of the techniques and ideas you have for just finding out whether people are struggling with specific inequalities? Could we start with David, I wonder?
Yeah, of course, John. So it's a great question. We increasingly are using our staff networks more and more to find out about the things that matter to our workforce. So we have an allies network, a reach network, I'll think of what the acronym stands for, and a set of carers networks and so on. So they are really gaining prominence in the trust in terms of focusing our attention on the things that matter to them. We also listen very carefully to our staff side colleagues who bring us information also about individuals who are struggling. We recently ran a reconnect and reflect session as part of COVID, which we've continued, which was a paid day out from work with a budget that colleagues could use to come together in their teams to just spend some time together to reflect and reconnect. And then we took the feedback back from that, from people about, you know, the things that they were finding difficult in their lives that we might be able to help them with as a trust, things that reflect our local communities. So I talked about Corby earlier, you know, those kind of issues came to the fore, and that allowed us then to put a program of support around those teams and those individuals. And we also used the data to tell us what teams are struggling for what particular reason. And we can see that at trust level, across our 250 odd different teams, we can see them segmented into different inequality groupings. So we have an idea of where people might really be struggling. So that kind of triangulation, qualitative in terms of listening to people, listening to those, you know, thinking of people as assets really, as champions for their own needs, and giving them a platform to explore that through our networks, and then looking at the data that we have about our teams that we can then triangulate using that inequalities tool that I referenced. That's kind of helpful to guide us in our work.
That's a great answer, thank you. And just going back to Phil, I don't know whether you're listening to Phil Harper earlier on.
A bit.
And Phil talking about a particular quote around treating everybody the same rather than respecting everybody the same. I think that's what we're getting to here, this willingness of employers to actually be open-eared and open-eyed, to be on the lookout deliberately and curious for inequalities amongst staff experiences and so on, domestically and in the workplace. Nicola, anything you might like to add in that regard?
Yes. So just before COVID, we realised that our colleagues were really putting the patient first, maybe at the detriment to themselves or even each other. So our approach that we've adopted, which is feedback from colleagues, is one culture of care. So that means that we look after each other in the same way we look after our patients. So through that approach, we've really kind of, it means things for different people. So we've adopted one culture of care charters for local teams so that they can make commitments to one another in the way that they interact with each other, support one another, and the way they deliver care for the patients who come through our doors. We've also well-being is a major part.
Sorry to interrupt. I'm very conscious of that. You're the only person I've interrupted so far, and I really don't mean it to be like that at all. But okay. It's just interesting what you're saying. How are you collating this data? Is there some kind of central repository for this data, or are you very much relying on individual teams and departments to look at it? Are you well, you tell me, how are you how are you using the information that you receive? How are you collating and then managing it?
Yeah, so we're collating it through our engagement and wellbeing team. So our engagement team facilitate the conversation locally in each teams, and we host libraries, and that library of One Culture of Care charters enable us to share that good practice to other teams. So as we all know, some teams and some leaders are really great at this stuff, but some teams and leaders are quite technical, so they don't really know how to deliver the basics around One Culture of Care. So by buddying up with another colleague who's excellent at this and giving them the confidence to host the One Culture of Care charters is really useful. And then what we then do, again through the engagement and wellbeing team who host regular walkarounds, is have an informal 4 to 6 month review and say, so how is this feeling for you? Have you set yourself an achievable goal, or has it been really difficult, particularly against the operational demands that you've been facing? So it feels quite informal the way that we collate it, and there's no real spreadsheets, or there's no real digital. It's very much people driven, and it is a lot of hard work, but it's really paying off by people walking around the trust and seeing One Culture of Care walls and seeing how people have put One Culture of Care into practice.
Oh, we like that. That sounds great, Nicola. I'm going to have to come up to Calderdale, I think, soon.
More than welcome.
You guys get a first-hand experience of it. Elaine, look, you work for a big old company these days. Oracle, Cerner, you know, this is not small potatoes. I would hesitate to speculate how many staff members it includes, but you can bet you've got your own inequalities going on amongst your workforce worldwide there. Have you got any insight you can provide that would kind of add to David and Nicola's points?
Yes, I mean, it's I would say our workforce, although they have a different job to do, we have got the same very similar challenges that have been called out, particularly around COVID and things like that. So our company practically went completely virtual, and that created you know, a very I don't know, it exposed how we operated in terms of how do you support people and how do you support different team members, so that we saw cultural things. So our leadership encouraged a kind of ground up approach to this. So it's maybe, I think, slightly different, but not completely different, but encouraged people to spend time together online, and created the environment where we could come together as groups, where we talked about knotty issues, and it wasn't all presentations and all of that stuff. It was a safe place to talk. And there was multiple different layers of that. Some came from leadership and some came from, you know, very junior members of staff who, you know, to set things up. So I'll give a specific example. Is culturally, we start to learn about different cultures, and members of staff would actually, you know, come to a religious ceremony or a religious event in the calendar year, and that member of staff from that religious group would actually spend time teaching us and sharing the joy of their religion, and making us more aware and more open and have a better understanding of why one might behave in the way they do, or make it more comfortable for us to ask questions because they're open. So therefore, we can ask those what we would perceive as silly questions. But that really came out because of COVID, I think. So those are the things that I think are a joy of having such a difficult time.
It comes back to understanding, doesn't it?
Yeah.
Being intelligent enough to pick up the signs that allow us to understand what's taking place.
That's right.
Devika,
and actually, some of those things are continued. They've continued, not some of them. The majority of them continued, and those engagement sessions. Okay.
Devika, is there anything emerging now that helps us that you're aware of to engage more fully and more fully with a workforce? Is there anything that you're aware of that may have emerged?
From a technology perspective, not that I know of, but I can do a scout on the ORCHA library and have a look for us and send it around later. But from a personal perspective and things that kind of I've done in the past in my organisations is I just think it's really important to create role models that the workforce can relate to at all different levels. Specifically, I think going back to another human example, because I love giving human examples, even though I work in tech and data, they work. Is that, you know, when I founded a tech company, but prior to ORCHA, and it was in the health and social care space. It was like the Uber for care. And so all of our workforce were predominantly low paid, low qualified women from ethnic minorities. And there was a lot of health inequalities going on. There was a lot of inequalities going on across the workforce. It was a really challenging space to work in. I found it was very, very difficult to understand and get to the grips of what was happening in these carers' lives so that they could actually care for the patients better and as well as they could. What we started to create in the organisation was storytelling. So it became a thing about people within the organisations could share things about them that were very personal, that they'd gone through, whether it was they were suffering from a disease, they were suffering from a chronic condition, they'd gone through domestic abuse, something like that. I started off the trend and talked about domestic abuse that I went through when I was in my early 20s with a relationship. And I had around 15% of the workforce come forward claiming that they were in domestic abusive relationships after that, which was absolutely harrowing, shocking, and all those horrible things you could possibly imagine. But it enabled not only for us to connect with these women and help them out, but it created such an environment of trust and openness in the organisation that we continue to do it. And the carers absolutely changed dramatically in their way of talking to us and communicating. So, you know, if others want to embed that, then I'm more than happy to share how we did it.
Oh, Devika, I am loving that. I mean, these lived experiences, isn't it interesting that often the most powerful insights just come from somebody who's brave enough to speak up about a lived experience, and all of a sudden everybody goes, oh, you know, that's me, you know, I've just been through that as well. And all of a sudden you get this vortex of resolution and positivity and determination to address it. David, we were this morning, we were privileged to listen to David Loughton, the Chief Executive of Royal Wolverhampton and Walsall Healthcare. And what David said was interesting. He said inequalities, it's never the same from day to day, week to week, month to month. You've got to be looking at changes that materially affect people who one day everything's fine. Something happens, and all of a sudden they're put in a situation where they're fearful of something or the other. And he was specifically referring to interest rate rises. All of a sudden you've got people in his organization who he would have assumed are confident, happy, well paid, you know, and all of a sudden these people are coming into work with slightly haunted looks on their faces because they're worried about hanging on to their homes and so on. And I just wonder whether there's anything that you might like to comment upon in terms of how you pick up on this. You know, once you find out it's a problem, what do we do about it? How do we empower your staff to then say, right, okay, we've picked up this may be an issue at the moment. This is one or two ways that you might like to tackle it. Any thoughts in that regard? Doesn't have to be about specifically, by the way.
Doesn't have to be about
mortgages and interest rates.
No.
Example.
Yeah, I mean, particularly on the cost of living. I mean, I'm sure everyone will have a comment to make on this. It is immensely difficult for colleagues at the moment, as we're seeing reflected in ballots going out to some of our nursing workforce. So there's no shying away from it. It is real. We're seeing market increases in people accessing food banks. We're really worried about our bands 2 and 3. I mean, I think there's a few things that kind of don't help, but I think the jury's out on whether the agenda for change scales have actually helped us with this, because there's a big jump between people who might want to earn more money, and indeed people do move when their circumstances change. They change jobs, they seek a different income to try and offset some of the pressures. So not having that flexibility in the agenda for change is kind of possibly unhelpful at this point. But again, jury's out. I think that's got to be part of some of the review work that's done. We've got a cost of living group set up with our trade union colleagues. I mean, just some practical things we can do. So blue light cards, you know, there's I think there's a £4 fee to buy those. They offer discounts across a range of places. That's practical. But as a trust, we can do that. We ran a scheme where people could bring their kids in for and eat free in our canteens across different sites. Got signposting in place to resources that might help people. We've explored offering people, you know, bonus retention type payments, which we did last year. We're looking at that again this year. But yeah, it's challenging and difficult for people, and we just need to accept that it will affect people in different in different kind of ways. And everyone.
Yeah, I guess the imperative here is for you as the employer to be seen, to be empathetic and thoughtful, and trying to offer any support and so on that you might. Would that be a fair observation, Nicola? I wonder how you're doing it up there in the north of England.
Yeah, so yeah, just like everybody else, the cost of living programme that we've got, we're trying our hardest to make it visible, so that our colleagues know that there's help from their employer. Again, touching on the Agenda for Change framework, the band 2 levels now are below the living wage recommendations. So we really need to start thinking about what kind of things we can do for our colleagues. So sometimes it's like really discreet things, like we have a top-up shop, so that colleagues can pop non-perishable items into baskets and then pick them up discreetly on the way home or on a lunchtime. But like I say, it's you know, it does not discriminate. So no matter which band you're in or no matter which role, it affects you in some way. We provide confidential advice and guidance through an employee assistance programme, providing financial education awareness schemes, as well as counselling, one-to-one support, and support for signposting for food banks and things like that. But there's so much more we can do.
Well, but I mean, already, what was that 2-minute answer? There's kind of 5 or 6 specific things that you're doing there that you've put in place. You know, that takes intelligence, it takes empathy, it takes listening, it takes understanding. You know, and you can just imagine if we kind of hoovered up all of the ideas from all around the country across health and social care, what an immense reservoir of ideas and solutions we would have. But we've never been terribly good at doing that. Well, look, Elaine and Devika, I'm Devika, sorry, I just want to move us along a little bit, if I may, because we've got managers and leaders here today listening to you guys. And the big question they've all got, I suppose, is, look, we've had data around for ages. Health and social care inequalities, provision of services and access to services, we've still got these problems. They are not going away. We can all talk about inequalities all we like, but solutions seem in short supply. We're not seeing any material change in the stats, basically, in terms of, you know, people having a problem with accessing services as a result of inequalities. I'm going to come to Elaine first with the question in this regard. What can we do more as leaders of our services at any level so that actually we are seen by the people whom we lead to be across this and interested in it and wanting to find solutions? So instead of it just being a problem that is nationwide and everybody's got it, and therefore I don't really feel in control to do anything about it, how do I, as a, I don't know, band 6 leader, nurse leader, for example, how do I show people that I want to do something about it for the citizens whom we serve? What might we do?
So I would say, and I said earlier, it's about being curious and really listening and understanding what's going on. And I guess that band 6 is looking after individuals. So it's that assessment of that individual person that they're caring for. It's asking those questions in a way that's open, so you're able to hear what's going on for them, because patients are very embarrassed about they're often, not always, but often embarrassed about what their position. And it's about how the questions are asked of them. So in terms of heating and food and finances. And I think for me, that's it. And we were talking earlier about how we approach things. For me, it's about compassion. So asking those questions with compassion. And I don't think there's anything else to say, because
no, that's fine. That's fine. It's a great answer. You know, we can overcomplicate this, but you know, one of the things that I think a lot of the audience would be thinking about today is, how do I become a role model for a demonstration of a determination to address this? And I suppose the answer is, well, you can run informal workshops with your teams. You can ask them, how could we, you know, start questions like that. How could we better address the educational needs of of the population whom we serve, for example? And there's a great question. I don't know whether you've seen it in the chat earlier on. I'm trying to find it now, from Lindsay, talking about that her local reading age is 7 to 11 years, and she's saying, how do you address health literacy in your services and areas of deprivation? You know, there are countless examples of different inequalities that just chip away at people's confidence and ability to access our services. So, well, thank you for your answer, Elaine. I think, you know, let's not overcomplicate it. Let's keep it simple. Devika, anything you'd like to add in this respect?
I definitely think this is where, this is where tech can come in.
Okay, give it us all. Give it us all. Come on, don't be shy. Don't be shy.
And I won't say it will solve all the problems, because I generally believe in what everyone has said here, which is it takes that human personal touch to be a leader that shows compassion and wants to ask questions and show the empathy. I think that's the most important part. But I truly think that tech can really augment a lot of the health inequalities, access to kind of health services or services in general that currently are, you know, really overstressed and overburdened. So especially with what we're doing, obviously with ORCHA, our key drive and our key aim is to try and get as much digital health into people's hands to support them and help them to manage their chronic disease states, or to alleviate the burden on elective care pathways, for example. So I think it all starts again with going back to education of our workforce. So educating that band 6 nurse that if a patient comes in and says that they have diabetes, they're suffering from depression, you know that there's a wait list of 6 months that could be there. What are the solutions that can be recommended to help that person to keep on top of their mental health or their lifestyle with the diabetes, and how best can we prescribe that or activate that patient so that they are using and engaging solutions whilst they're out. I think that's where we really fall down on. I don't think within the NHS especially we utilise the availability of digital health solutions enough, and then also empower our workforce to be able to use and recommend them. So that's where I would say we could really benefit a lot from.
Okay, I'm going to come back to that in a moment or two, because there is you've probably seen in the chat from Morgan, there's a really good kind of challenge to that, which I think would be worth making. Elaine, I'm going to come back to you if I may, and then go to David and Nicola to kind of finish off a little bit. From an EPR, an electronic patient record perspective, are you starting to develop anything that can actually capture information about individual patients' difficulties and that kind of, I mean, is that even ethical? Is that something that we want to capture, or is it something that we'd rather not? You know what I mean?
Well, yes, and I think there's two aspects to that. So there's the individual professional assessment that captures individuals' information about people, their financial status, or whether they're working or not, rather than their financial status, whether they live, what kind of housing they live in, and whatever, all of those kind of things. So that can be captured locally in an electronic record. And then there's the other part, which is the patient's interaction with their.
That's the bit I'm really interested in here.
So there's the personal interaction that having a portal or a personal health record is useful for, because then there's the exchange of information. So the person can put information in that themselves, but also there's the feeding of information to the patient as well. So an algorithm might have identified something, and you can push out an activity or information or education to the person so they can consume that. And in the same way, then you have the cycle of information coming back so that you can identify if they're at risk or if they need some intervention. So those things are, you know, available and used, albeit that they're at first generation level. But that consumer part is extremely significant. And I think that's the biggest next thing, if you like. Because what it does is enable personalization. So you can start becoming much more bespoke in the interactions you have with between an individual and a professional.
Well, that's kind of the direction of travel I was angling towards. David, would you like to comment on this? Are you using anything of this nature in Northamptonshire, and what kind of an effect is it having, would you say?
Well, just to endorse Devika's kind of use technology. I mean, I think there is a big space emerging for us in terms of how we approach that. In my old role, I was a managing director at a clinical commissioning group in Northeast London, and they have a Once for London program called Good Thinking, which is an online repository of mental health support for young people, linked to social media. So if people were Googling or looking for self-harm or expressing suicidal ideation, they would get some bespoke adverts pop up, which would lead them to the Good Thinking platform, where they could access some of the self-help curated resources, NHS curated resources. The numbers on that were immense during COVID. It just went exponentially grew in terms of people's needs. I think one thing that hasn't been mentioned is the voluntary sector. They are absolutely critical to us in any community that's working with deprived communities. The voluntary sector are really, really important. And I'll just give an example of that. Again, just quoting my previous role, but we're doing some of it here as well in Northamptonshire. We had a big Turkish community in Hackney. And you might know there's an NHS program called IAPT, Improving Access Psychological Therapies. It's got a national performance standard. You have to deliver 50% recovery for the resource you get. We struggled with the Turkish community, really, really struggled. 25% recovery going through the program. So we spoke to the voluntary sector who introduced us to the community. We listened, and they said, well, actually, in our home country and our original culture, we would be outside and communicating in an informal way with our families and with our friends. So we set up a horticultural therapy session, and the therapy rates went up above 70 and 80%, exceeding what we were achieving in any other demography. So those kind of things, I think, the digital bit for sure, but also the real basic stuff, our voluntary sector, our local entrepreneurs, social entrepreneurs that are doing all this stuff already whilst we're waiting to catch up with them.
Thank you, David. Nicola, would you like to add anything in here from the respective Calderdale and Huddersfield? How are you empowering your staff to take control of the information that they receive from the patients themselves, so that actually your staff feel empowered to do something by way of addressing them?
Yeah, we have a program called Work Together, Get Results. And that whole program is around visualizing the art of the possible. So local teams can run their own sessions and facilitate their own sessions using the feedback that patients have given them, or even observations from themselves. I agree with the panel. Innovation and digital is definitely the way forward, and it's them championing. So if this is the art of the possible, how can we lobby for funds to make that possible happen? It could be something really, really small, but which would make a significant difference.
Perfectly put. Thank you. I do have to address Morgan's point that she put in the chat. She says there are large pockets of our local population has quite a high level of digital poverty. Everybody on the call here would recognize that, absolutely. Is there anything we can do about that that's kind of deliverable quickly? I know lots of organizations, including some of the banks, even have have tried to address that. Is there anything that any of you have found really helpful or effective in that regard?
Buying people data has helped us a lot. So putting data on people's SIM cards, or even buying them phones, smartphones, so they can access the information much cheap. You can get a smartphone for, you know, for the cost of a therapy session. So that's turned around some of the people, certainly people with some serious mental illnesses have really found that life-changing. They can access crisis support really quickly, all of those online resources.
Yeah, we did the same. Absolutely. I think one of the biggest things we found with my old company was that the biggest hindrance to, or the barrier to, the carers actually utilizing and using the app that we created, which was all about them checking in when they got to the house. We could see when they were arriving. They were going to give us all of the data about the caree on the phone, etc. Was that they didn't want to use their own data to track all of the services, and because they don't have the money, and it's completely understandable. So yeah, I completely agree with you. The simple solution, which again is the most obvious one, was to just buy them a data SIM card, and it worked wonders. So sometimes the simplest solutions actually work the best.
All right, there we go. Look, I wanted to try to provide 5 minutes of questions from the audience today, and I've managed to come in just bang on that. So would anybody like to ask any of the panel a question? If we could keep the answers relatively short, so that we may get time for 2 rather than just the 1. Would anybody like to ask at all? I know you're all curious, so you know. David Brewster's got his hand up. Thank you for saving the humiliation of the panel.
No, but I think it's more an observation, John, to be sure.
Go ahead. I'll take anything right now.
What I've really taken from this conversation, thank you very much to the panel, and it is true, it's the human and the digital. It's actually how the two work together. And that is through education, making it available, and so on. There is a place for digital, and we've seen that throughout today. But it's actually how do we as leaders, managers, organizations make it available to use by patients, staff, the organization, and so on. So I think it's what a great way to kind of come to the end of the day, bringing all that together through that last round table. Brilliant. Thank you very much.
Thank you, David.
John,
yes,
could I just
go ahead? Yes, of course.
Add back to that. I think that's a really important point, and I would ask that us as leaders that we role model with how to use digital and what impact it can have on individuals. And if we use it, because I mean, I'm going to make a sweeping statement, but when we're kind of professionals or of a different generation, we tend to not maybe use things as much as, or in the way that young people are using things who have grown up with technology. And I think some of that modeling as a leader and showing how easy it is, or recognizing some days that it's really hard to use it, but actually please do persevere, because this is the benefit that you get from it. So I think those are the things that I would ask us as leaders to do, I guess.
Perfect. Thank you, Elaine. Devika, yes, final word from you.
Yeah, no, I think that's completely and utterly correct. And that this is something that ORCHA did, which I think it would be really good to share on here, is that we created a digital health academy that's actually free for all NHS staff to use. It was launched earlier this year, and essentially it takes you through 2 different foundation modules, all about how you engage with digital health, how you use it, how you prescribe it, how you recommend it. So to your point, Elaine, that's free. That's a free resource. And I think for us, the main aim with that was, how do we get people to understand and become digital literate, can't say that word, which will then obviously have a massively positive effect when it comes to helping other workforces and helping prescribe and recommend solutions to, you know, patients and members that we really need to have access to it. So yeah, just a point there in case anyone's interested in, you know, using it.
Thank you, Devika. Well, look, I've really enjoyed that session. The time has absolutely zipped past, but I don't think anything better has come up than, I think it was David's original point about, or it might have been Elaine, just about curiosity. Just, you know, be that leader, be that manager who is constantly looking for signs of, you know, a problem, an inequality, a problem accessing a service or something, if we preserve that curiosity in our leadership behavior, then I think we're not much is going to get past us, and then we can do something about it. There's that I'm a big fan of Professor Beverly Alamo Metcalf, as some of you may know Professor Beverly, and when she talks about the follower needs, and the number one follower needs is that you demonstrate genuine concern for the people who you lead. I think if we embrace that, and for that so that means we ask questions of them to find out how they are. And if we keep that at the core of what we're doing, we're not going to go far wrong, I don't think. Look, my huge thanks to Elaine and Devika and David and Nicola. Weren't they great, everybody? Weren't they absolutely fantastic? I told you they were going to be good. But they were absolutely outstanding. Thank you all. Nicola, I'd love to have the privilege of coming up to Calderdale and Huddersfield soon to meet you all and see what's going on up there. David, I had the privilege of being in Northamptonshire quite recently, and I'm coming over again soon. Elaine, it's been too long. Devika, please give my best wishes to Liz. We're very grateful for her continued support. And I've got to can I just give a big shout out? There's one member of the audience today who, do you know what, he's attended every single session, and he's been tweeting after every single session about the lessons that he personally has learned from it. So a big shout out, Chris Picknett, thank you very much. I mean, what a fantastic demonstration of membership loyalty and value. So congratulations to you, Chris. I think that's a lovely thing to have done. All right, have you enjoyed yourselves, everybody?
Very much.
Say yes, otherwise I'm just going to feel flattened now. Huge shout out as well to Jade Maloney, our queen of virtual conferencing, and our operations manager at the IHSCM, who has really coordinated all of this behind the scenes. Jade, you've done an absolutely first-class job again. Thank you very much indeed. All that remains for me to say is thank you to all of you for tuning in throughout today. And if you are watching this on catch up, well, you missed it live, but at least you're going to get it secondhand. You're not going to miss out too much. Thank you all ever so much. We will see you on the next one of these, whenever that may be. Bye-bye.